Okay, our next speaker is Dr. Amy Patel, and Amy is with Liberty Hospital Medical Center. Amy?
Yes.
Okay, so hi, thank you for this invitation. I'm really excited. It's my first Male Breast Cancer Coalition meeting, and it's just been wonderful listening to the stories and just everyone that's come together to advocate for male breast cancer. So my area of expertise, I'm a breast radiologist, so I'm going to be focusing more on male breast cancer imaging updates. My background, since I'm new to the crew, so I'm actually the medical director of the Women's Imaging Center at a Liberty Hospital in the North Kansas City, Missouri area. And I'm also an assistant professor of radiology at UMKC School of Medicine. I was recruited to come back to the area about 2 years ago because there was such a need of subspecialized breast care in the area. I was on staff at Beth Israel Deaconess Medical Center in Boston, Massachusetts, and on staff at Harvard, but I'm actually from rural Missouri, and there's such a need for subspecialized breast care in the area. So I felt sort of a calling to come back. And so now I'm in town, and then I connected with Peggy and Brett, and it's just been so amazing ever since. So again, I really appreciate the opportunity. And I just have a few slides to talk about male breast cancer imaging updates. Okay. So as you all know, male breast cancer is rare. So, for example, we see female breast cancer, 1 in 8 women will get breast cancer, but in men it's 1 in 800-ish. However, the incidence is rising, so that's important to note. And as many of you know, there is an increased risk in certain mutation carriers, such as BRCA2, which has an association with prostate cancer. The most common type of male breast cancer is invasive ductal carcinoma, which is the most common kind in women as well. It presents the same as in women, but it is more aggressive than in women when diagnosed. And again, these are a lot of facts I'm sure most of you know. According to the American the American Cancer Society 2020 estimates, there will be 2,620 new cancers, invasive cancers in men, and about 520 men will die from breast cancer. So those are just, conservative estimates from the American Cancer Society for this year for men. And then, of course, as we know, there are risk factors associated with male breast cancer, hereditary syndromes, a family history. For example, those who are Ashkenazi Jewish, they tend to be BRCA mutation carriers. So there are risk factors associated, of course. So genetics, I think we've probably talked about this already. I'm sorry I wasn't able to attend yesterday, but there is evidence linking genetic mutations to so many mutations. We know a lot about, BRCA2 right now. We know, for example, CHEK2, if a woman has CHEK2, that they are 2 times more likely to have breast cancer versus a man who is 10 times more likely. So that's just really incredible, such an impressive risk for men. However, as the theme has been during this meeting, we just need to push for more research. We need more research in this realm to understand these risks for men. Now, regarding male breast imaging, the current recommendations as stands, there's really no current widespread screening recommendations, and it really varies per practice and institution in high-risk men. So, for example, some institutions and practices, I would say the majority, unfortunately, if a man is high risk, they're not really getting any type of screening. When I practiced in Boston, we were screening high-risk men every 2 years, and 1 to 2 years, depending on what their primary care provider was okay with, because that was also another battle we had as well. And where I am now at Liberty, we do screen high-risk men. If they are at high risk, we actually screen them annually. But again, this tends to be in the minority at this time. I think until more research comes out with high-risk men and breast imaging, that it unfortunately won't be the norm, and that's why we have to push for it. Now, if they're symptomatic, it's a different story. particularly if they have breast pain or a palpable abnormality. And what we follow is the American College of Radiology Appropriateness Criteria Guidelines. So if the man is under the age of 25, we start with a targeted ultrasound. But if they're 25 and over, we start with a diagnostic mammogram and then ultrasound if needed. If they're under 25, we do an ultrasound and it looks suspicious, not necessarily classic gynecomastia or something like that, then we may, at the discretion of the radiologist, have them have a mammogram to see what's going on. So that's the current guidelines for symptomatic males. But again, unfortunately, there's no widespread screening recommendations at this time in men. So there is more evidence now that suggests high-risk men should be routinely screened. And again, like I said, we are pushing for this, but we need more research to make this a standard of care measure. But, the good news is there is that big push from our breast imaging community to focus on male breast cancer imaging and cancer research. And it's also imperative that we come together to do research from different parts of the country. So, for example, particularly where I practice, there's a lot of breast cancer, And I think the reasons are multifactorial. There are very strong genetic family histories. I think there is an environmental exposure component as well, farmers and, pesticides and things like that. But, for example, so we see a lot of breast cancer there, but a lot of this research is done particularly in the big urban cities. And so one of the big institutions that focuses on male breast cancer imaging research is Memorial Sloan Kettering. And I actually had a great conversation with their section chief, Elizabeth Morris, about how, they agree too. We need to be pushing for more breast imaging research and diversifying the data. So we're actually going to be working on something together where we're looking at data, not just from New York and that population, but mixing, the data from our area and other parts of the country, because diversifying the data is very important, and to look at all of these different demographics in the United States and beyond. So as far as the literature goes, this is probably one of the most recent manuscripts that was published, most recent research that was, that we know about in the field of breast imaging. So this was a study, this was published actually last year, September, October, that was conducted at NYU actually. And this was a 12-year longitudinal observational study of male breast imaging utilization and outcomes, particularly in high-risk men. So their results demonstrated that mammography screening in men who are at high risk yielded a cancer detection rate of 18 per 1,000 exams, higher than cancer yield among women with average risk of 3 to 5 per 1,000 examinations. And mammographic screening, depicted occult malignancies, meaning that the patient didn't have a symptom. You just found it, or they found it on imaging, or the clinician wasn't able, their primary care doctor wasn't able to palpate the abnormality or anything like that. And they were all early. So that's really great because it improves your prognosis. So this was a really groundbreaking study, again, demonstrating the need to push for regular surveillance, particularly in high-risk men, and continue to do research to see if we need to go beyond that. So my key takeaways is, although male breast cancer is rare, the incidence is rising and symptoms should not be ignored to ensure proper evaluation. Particularly with the pandemic, we are just kind of waiting with bated breath to see what happens. The NIH is conservatively projecting an additional 10,000 breast cancer and colon cancer deaths over a decade. And what's going to happen to men in that category? So we're watching this. And we as a breast cancer community, we need to just push for more research of male breast cancer and diversify the data and look at different geographic locations. And we need to advocate for widespread acceptance of regular screening in high-risk men. We do such a great job advocating for female breast cancer, but we still lack significantly in male breast cancer. So we just need to push for it. And with that, ensure insurance coverage of these patients. I think that a lot of times we talk about how we want these things to happen for men who might be predisposed to breast cancer, but we don't look at the insurance issue. If it's a diagnostic mammogram where a man has a symptom, it's much more likely to be covered than if it's just a regular screening mammogram. It's less likely to be covered in multiple states. So we really need to ensure that they're also covered insurance-wise as well. And that's all I have. Thank you. If you have questions, I'm happy to answer them. Otherwise, this is my email. All my emails go to my Gmail. So I really appreciate your time and attention.
Thank you so much, Dr. Patel. Who would have questions? Dr. Jay Harness?
Hey, that was an outstanding presentation. Congratulations. I don't think I heard a definition of high risk. Is it just gene positive people, family history positive? I think that would be helpful to have a definition of high risk, but outstanding presentation. Thank you.
Yes, thank you. So when we look at above average risk patients, we are talking about a 20% or greater lifetime risk of breast cancer. So not only is there a genetic mutation component, but particularly when we talk about above average risk, for example, in women, there are multiple factors that contribute to your risk. For example, your breast density, your body mass index. We know that obesity is a risk factor for breast cancer. The family history is important. So, but typically by different breast cancer risk assessment tools, we deem above average risk or high risk at 20% or greater lifetime risk.
I'm aware of that, but in men's, I was talking about high risk for men specifically.
Yeah, so, specifically for men right now, and, Dr. Parker, any others on who want to chime in, we look, again, we're significantly lacking, and it is a shame, but particularly these genetic mutation carriers, that helps us the most. So, patients who have a very strong family history, we do push for them to be genetically tested. Those who have maybe a history of prostate cancer as well, we know there's association with BRCA2. So I think a lot of it, particularly with high-risk men and breast cancer, we look particularly at the genetic component. But if Dr. Park would like to add anything as well, please do.
I don't have a whole lot to add, but yeah, I think it always goes back to the same old, that we just don't have enough data and information, and that doing more research in this field is sorely needed. But I saw Lopa had her hand up. I don't know if you wanted to add.
Yeah, so, mostly another thing as high risk, what I noticed was the occupation. So a lot of people working in the environment, like exposed to radiation or like atomic centers, that is one of the cases. And the other, I feel that always also, like we have in North Carolina, the Camp Lejeune, right? What happened with the water. And so kind of like, because everything plays a role too, like the environment. And that's what I was trying to say, that the study is so important with the water, the contaminants in water. And that's what happened with the marine base in the Camp Lejeune, because they were all drinking the contaminated water that led to so many cases of male breast cancer in that area. And Mike Patel is one of the candidates who was there for the MBCC conference. So those are the other risk factors. And I have noticed that, besides whatever Dr. Patel has mentioned and Dr. Park said, that there are so many other reasons can be. And also randomly, anyone can have it, but one question also I had for Dr. Patel. Thank you for the great presentation, Dr. Patel. So when we come with the breast radiology, right? So at that point with women, we have a lot of issues with the dense breast. And with men with such less amount of tissues, do we have to worry about dense breast? Because I tried to look up a lot of places, but I couldn't find much. Maybe is there like no fibroglandular tissue, or what's the composition of the tissues you usually see with the male breast candidate?
Yes, that is an amazing question. So particularly in male breasts, we tend to see, so for those of you who may not be aware, whenever we interpret a mammogram, there's 4 different breast compositions. And so we have to designate one of those. Fatty breast tissue, where most of the breast is just fatty, which is much easier to detect cancer. Scattered, where you start to see some wisps of fibroglandular tissue. Then heterogeneously dense breasts, where you start to see a lot of dense tissue, which appears white on the mammogram that can obscure masses. And then extremely dense, where the sensitivity of mammography is significantly lowered in the detection of cancer. So particularly particularly in men, we see scattered and fatty breast tissue. And even if they have a very pronounced case of gynecomastia, where you have this proliferation of fibroglandular tissue that emanates from the nipple, even in that regard, we tend to see more fatty and scattered tissue. So in men, we don't really deal with dense breasts like we do in women. And a lot of that has to do as well as hormonal exposure, estrogen, progesterone, which those levels, of course, typically are lower in men than females.
Perfect. Thank you so much.
I have a
Okay,
question.
any other questions? Oh,
Yeah.
go ahead, Ron.
Yes. For men who have had a mastectomy, I was in a situation where they couldn't do a mammogram on my breast. They said there just wasn't enough tissue. Is there any other things they can do? Some other tests they can do from an imaging standpoint?
Yeah, so that is another really great question as well. And unfortunately, you know, if a woman has had a mastectomy as well, the standard guideline is, you know, that we don't screen that side of the breast, because typically there's not enough breast tissue to image on mammography, unless it's like a partial mastectomy or not a true mastectomy where there's enough breast tissue to image. So unfortunately, right now, there's no particular standard guideline with that. However, if a patient feels a lump or something, then ultrasound would be the go-to, and it is also cheaper as well. So some patients we have want to have that whole chest wall screened annually, and we're absolutely okay with it, but they need to know that typically, you know, insurance may or may not cover it. So we always tell them, please check with insurance to see if this is covered. Also, one of the things that you can do particularly is a breast MRI. So breast MRI, the indications for breast MRI, one of them is if you are at high risk for breast cancer. Well, if you've had a history of breast cancer, your risk is 100%. So some people will go ahead and do an MRI. However, again, we always tell patients that insurance may or may not cover it, so definitely check with your provider. Luckily for us in Missouri, I was really fortunate to work on high-risk legislation, which just passed in the Missouri legislature, and the law becomes effective August 28th, where if you are deemed high risk, above average risk from breast cancer, whether you're male or female, you have to be covered by insurance to have that screening, whether it's ultrasound or MRI. Unfortunately, that kind of legislation varies significantly in the United States.
All right, do we have any other questions? We can't thank you enough, Dr. Patel, for being with us, and great information. And again, I've added her email into the chat window, so you have that.